What about the injured child? What about the kid that falls off the trampoline, smacks their mandible, and incurs a macro trauma? They tear ligaments in their joint. And all the I'll watch it philosophies that our profession tends to put them through, for example, or the skeletal class 2 patient, the patient that with a retrognathic mandible. And you see them in profile and you know the mandible never grew, right? Well, you don't know if you don't know what you're looking at.
Well, I think we have always had a very strong bias in the TMD world that we were going to be treating adult patients who suddenly develop pain.
Right.
Or maybe a teenager who gets into pain. But pain in the body is our final warning sign that something bad has happened. And especially in acute injuries, there may be some discomfort, but patients will shake that off.
Yeah.
And then over time, as damage progresses in the joint, then they may get to a painful state. Children are totally different from the adults in that they can go years before they start getting into facial pain or headaches or whatever. So what's going on in the child patient is basically a structural defect. They have a bad bite, they have a crooked face, or a chin that's off center, or a lower jaw that is short, or a very gummy smile, or they can't bring their front teeth together. And we end up as dentists looking at the teeth, and we miss what's going on at a deeper level in their foundation. And I tell people, this is a point in time when we have a child patient with an injured TM joint. The point in time is when we look. And a lot of times we begin to look when they're ready to have braces.
Right.
But they may need braces only because they injured their TM joint years before that.
And no one looked.
And nobody looked. And they're still not identified as a TMJ patient. They're identified as an orthodontic patient. And mom and dad are told that they have to have teeth extracted, or that they may need bite surgery later on if the orthodontist can't finish the case. That should be a warning sign that something bad has happened to the joint foundation. The next point in the timeline for the child patient becomes at the end of growth, there's a period of time where they begin to hurt.
Yeah.
And once they begin to hurt, then dentists start looking at the TMJ foundation. In the world that I live in, many times that's too late.
Right.
Because they've already deformed to the point where they're hurting. It's very, very difficult to reverse damage in the structure.
That's orthopedic.
That's orthopedic.
It's not necessarily dental. It's manifesting where we can see it as a tooth bite issue, but the reality is you've got something going on in the back, the hinge.
And it's really all about growth center mechanics. You could have a young child break their growth plate in their wrist, and that growth problem may develop and they'll end up with a deformed bone. It may not hurt later on, but it'll be deformed until such point that they develop arthritis or some kind of a secondary side effect of that original fracture.
Sure.
The growth plate in the TM joint is extremely sensitive to the malalignment or alignment of the disc. The disc has to be in place. And if that disc is out of place, that's like going into the middle of a growth center in a long bone and just disrupting all of the cell lines so it can't develop. So anyway, the child patient is really the critical patient in my opinion, because they may have early injury. Initially they present as a bad bite needing braces. Then they may present as a bad skeleton needing skeletal surgery, and then they may get symptomatic and require splints and require bite adjustments and restorative dentistry, revision of their bite work or bite osteotomy again. And you know what's at the end of the timeline? Apnea.
That's exactly.
So those patients become the apnea patient of the future.
Yeah.
And so the question becomes, where do we get to pick this patient up, and what can you do at the point of entry? It depends upon how astute the dentist is in picking up a structural problem in the TM joint in a patient who has no pain.
Right.
And not only do they not have pain, but there is a bias against working up skeletal problems and bite problems by looking at the TM joint. We don't do that, but we need to.
Well, there's a few of us starting to do that now, thanks to you,
I understand.
looking at the back. And there's a few of us starting to look at the front. And if we could get people, I mean, general dentists out there, most probably won't go to the imaging, but if they could start learning to look for the signs that precede the symptoms, such as the anterior open bite or the profile, the chin,
Yeah.
the floating bite. The left TMJ is illustrated. Blue means all teeth touching. This is the cartilaginous disc. There's a lateral and a medial pole. The sagittal view. Notice the posterior band of a disc at 1 o'clock. Notice as we change the cartilaginous disc to 12, 11, 10, 9 o'clock positions, how things change in the glenoid fossa. Returning the disc to 1 o'clock normalcy, look how things change back again. From a distance, watch how tearing cartilaginous disc changes the occlusion. Blue means touching, white means not touching. The anomalous medical software does a wonderful job displaying the changes that the bite may undergo resultant of backside joint changes. Leaving the left side TMJ at 9 o'clock, now we move to the right side and start tearing cartilage on the right side TM joint. Notice how the occlusion changes even more. And the back teeth are constantly contacting. Notice the front teeth are not contacting when both joints have a 9 o'clock positioned disc. An anterior open bite, this is very important. Changes in the joint readily affect the occlusion.